Hi, everybody. So we are going to start off with a disclaimer. So by participating or listening to this content, you agree not to use the information presented here as medical advice in treating any medical condition. This forum does not constitute a provider-patient or physician-client relationship. The content here is for informational and educational purposes only, and because each person is so unique, please consult your healthcare professional for any medical questions.
Thank you.
And then, did you want to do the introduction of the group, and then I'll read Dr. Frye's bio?
Welcome, everybody. My name is Cindy Brown, and I'm really happy to have you joining us this afternoon. I'm also very happy to have all of you as members of the Autonomic Dysfunction Facebook support group. If you have ideas and for new topics coming forward, please share those. I'm also very happy to introduce Morgan Hart. Morgan is my co-administrator, and she helped me get the group going, and I always have to be proud of her and say that she was knocked down at 15 years old and, thought her future was over, and she's in her last year of physician assistant school, and she is interested in helping to treat POTS patients. So love bragging on her. I can't help it, but welcome, everyone. We're so happy to have you.
Alrighty, so let's go ahead and introduce Dr. Frye. He is a pediatric psychologist in the chronic pain clinic at Johns Hopkins All Children's Hospital in St. Petersburg, Florida. He specializes in non-pharmacological treatment for patients with acute and chronic pain conditions and provides skill-based interventions for simultaneous psychosocial concerns. About 30% of Dr. Frye's patients are diagnosed with POTS, and he joined the hospital staff in 2018. He earned his doctoral degree in clinical psychology from Auburn University. He completed a pre-doctoral internship in pediatric psychology at Children's Mercy Hospitals and clinics, and a postdoctoral fellowship in chronic pain at Nationwide Children's Hospital. Dr. Frye's research interests include pain coping and catastrophizing and parental impact on youth outcomes. He's board certified in Biofeedback by the Association for Applied Psychophysiology and Biofeedback.
Welcome, Dr. Frye.
Hey, thank y'all. Well, I'm going to go ahead and share my presentation, but while I'm pulling the screen up, all right, making sure, can everybody see this okay?
Yes.
Yeah.
All right, great. Let me turn it on from beginning. There we go. First, want to thank Morgan for that introduction, as well as reiterate what she said. This isn't medical advice, and while I am an employee of Johns Hopkins All Children's Hospital, this does not constitute as the views of the hospital. They're my sole views alone. With that said, this is an area that's a really fun topic for me to talk about. As was mentioned, my primary training has been in chronic pain, but through that, easily started seeing lots of kids with dysautonomia. And I am a pediatric psychologist, so I work just with kids and young adults up to age 21. But with that, there's something that came up over and over and over again, and it's this relationship with mental health, with symptoms, with diagnosis, and honestly, with conditions such as chronic pain, but especially with different types of dysautonomia. There's a lot of misunderstanding, especially amongst the medical community, which unfortunately affects you, the person that's experiencing dysautonomia. So what I hope to do today is talk a little bit more about just that relationship, and the objectives I have go along with that. So first, I want to talk about the physiological aspects of dysautonomia, knowing that there's a lot of different ways this can look, but just some of the basics. And then we're going to talk about the relationship between dysautonomia and mental health. And so I'll try to give most of the information that's out there in the field right now, although this is still a really young field in terms of research and what's been done. Next, I want you to get something from this other than just some education. So we'll talk a little bit about some practical tips, things that I've seen that have helped usually with kids, but hopefully can be applicable to anybody regardless of your age. And then lastly, the role of psychology, especially the good parts of psychology. I don't want us to be seen as an enemy. Rather, I'd like us to be seen as somebody that collaborates and helps with your care. So let's get started. First, when we're thinking about dysautonomia, we're typically thinking of some problem with the autonomic nervous system. That's what this picture is. And if you can see in the picture, this is a very complex nervous system and really impacts all the major organs of the body, which then causes all these different symptoms that can occur in places that seem unrelated. And when you have these complex and challenging symptoms, it can be hard to treat. It can be hard to get diagnosed, and probably many of you have experienced that. And with this, there's lots of organ systems involved. So then you're going to be seen by different providers. And generally, this just impacts life in a lot of different ways, depending on what your symptoms are, depending on what you're experiencing and what's been happening. And so the impact, which we'll talk about here in a little bit, it can affect everything. And I think this is something you all relate to. It can be school and academics, work and occupation. It can be your social life, or even just having to go to all these appointments and see different doctors and really work through that. And so this is something that can really be effective on the life, or excuse me, really affect the life. And one of our first things we have to think about is, where does this come from? Now, if you see the picture again, there are a lot of different conditions that are enveloped inside the dysautonomia umbrella. Generally, I'm just going to talk about concerns with the autonomic nervous system and some of the findings and thoughts that broadly apply. But please know that everybody's a little bit different. So this could be if, for instance, if we're thinking of what condition you have, it's going to be a little different. If we look at the conditions down here, somebody with orthostatic intolerance, or maybe they've met criteria for POTS, they're going to have different symptoms. Even two people with the same condition are going to have very different presentations. And so because of that, and not just the presentations, the way they got there, again, it can be hard to diagnose. As mentioned earlier, this is a failure of the autonomic nervous system communicating with the body, but it can get there from a lot of different ways. So for one, we know genetics can play a role. Unfortunately, we don't have a specific gene to say, hey, here's what causes it. But we often see that this is seen amongst family members. So if you have a parent, it's often likely that the kids will have it. It'll be there between siblings with similar symptoms, but not always. There's some information that would say that some types of dysautonomia are autoimmune mediated. So you have an autoimmune condition, and this comes up secondary to it. Infection as well. So an illness can cause this. There's several different types that can lead to different types of autonomic dysfunction. And then things like traumas, whether we're talking about some type of health crisis, we're talking about a really bad injury or concussion, we're talking about an illness that came from medication, or even from a trauma, if we're thinking more of emotional trauma. Any of that can also help lead. And then health behaviors, we have to throw that in the mix as well. There's some information that would say that cardiovascular deconditioning is related to different types of dysautonomia, but that's more of a correlation. It means they're related, but it doesn't mean one causes the other one. Really, though, we have to use all this information and decide, okay, where does it come from? And it's going to look vastly different from person to person. Again, becomes kind of confusing, not just for the doctors, but even for how am I treated? And that's why oftentimes we need an individualized plan. So the things that work for one person on this video are not going to work for the other person watching beside you. So something to know in this. Now, while we don't always have a clear route to how do we get to our symptoms, sometimes we do, but not always. And we don't always have, here is the perfect treatment plan for you. I wish we did, because otherwise some of you wouldn't have as much difficulty you're having right now. But you don't have that. Rather, the way we start is typically with some general non-pharmacological recommendations. Now, I do want to say these are not the cure. I don't think that's how this works. Rather, these are just things that we have people start to consider using, things that we hope will help out with their symptoms, things that we hope will help out with their quality of life. And they're the least invasive. They have the least side effects. They're usually the easiest to get started with. And so medications, obviously, they're part of this. A lot of you probably are taking medications, and some of those medications really might change how you're experiencing life, how you're experiencing symptoms. That's a little bit outside of my scope. I'm a psychologist, so I can't really comment too much on the meds. But I can talk about some of this. And if we work through this slide, Exercise is one of the big ones, and in almost every treatment plan, there's some aspect of physical activity. Don't have to be an athlete, but usually, or almost always, being somewhat active can help, just because it helps with cardiovascular conditioning, really getting the blood to the heart, getting the blood throughout the body, not letting it pull or sit too long, but really move more efficiently, as well as just building up muscle strength, especially lower body. Again, that's going to help move the blood through and also help out with some symptoms. Hydration and salt, I feel like any group with dysautonomia has probably heard this a dozen times, but that also helps with how much volume you have in your body and can be really beneficial. And then there's counter maneuvers. I won't go through all these because there's well over a dozen, but this is really thinking about what are the maneuvers that allow you to have less symptoms, especially if you're feeling like you're about to faint or fainting. A lot of this is involved with squeezing your muscles, crossing your legs when you're standing, things like that. You can go online and find plenty of different counter maneuvers that people have suggested before. And then lastly, we have the mental wellness piece of this. I'll talk about this a little bit more in depth, but it is part of the treatment plan. And the reason for that is when we're thinking about where mental wellness lives in the body and in the brain, it works on the same nervous system, typically, the sympathetic nervous system, if we're thinking about stress or anxiety. That's part of the autonomic nervous system, same system that most autonomic dysfunction works on. So what do we know about this? Unfortunately, there's not a ton of research on mental health and dysautonomia right now. In fact, I'd say it's very much understudied. Now, in the research, I have a few of the highlights up here. We're going to get on the worst column first. Typically, what we find is that if we're looking at a sample of people with dysautonomia, with some type of dysfunction with their autonomic nervous system, we're going to find that they have more anxiety than a healthy sample, which makes sense. I would expect so. It's a population that's having symptoms, they're going to have more anxiety. And there's also higher rates of depression. And even one study found that there's a higher suicide risk. Now, granted, most of these are relatively small studies, but still are things to consider. And it makes sense if we're considering all the things in life that may be occurring. However, there's other studies that show there's not much of a difference, that say, yeah, compared to the population that's very much healthy, there's not a whole lot of change. Maybe there's some moderate depression, but it's not that different. There's no real relation to anxiety with dysautonomia. And then lifetime prevalence, there's been mixed results. Some studies saying, oh yeah, there's a big difference between anxiety and depression in those with dysautonomia versus those who are a healthy population. Other studies say there's not. So we're basically looking at a body of literature that doesn't have really strong evidence either way. And this makes sense to me, because the studies we have are really small. And if we're looking at lifetime prevalence, this is still becoming a more popular condition that is just now by some of the medical community being considered a real thing, which is silly that it's taken that long. But it's something that researchers haven't really got around to. And I expect it might be another 20 years till we really have strong evidence for here's the prevalence and numbers like that. But I don't think this matters too much. This kind of gives us a glimpse of, yes, there are problems. But again, this is very individualized depending on what's going on in your life and what's happening to you. And so it's something that providers need to be aware of, that mental health can be impacted, but something we need to learn more about. All right, let's go through these though, especially anxiety and depression. I have a bad relationship with this one. I'll tell you why. It's because whether it's in pain clinic or whether it's stories from my patients who have dysautonomia, many of them have this same experience, which is very unfortunate, where a doctor said, oh, I don't know what's going on. You have anxiety. Well, that's what's causing your symptoms, and you're depressed, and that's what's causing it too. But what they don't really consider is the flip side of that. Could it be that somebody who has all these symptoms with their body come up at one time, get a little anxious? And when you don't feel like you have control of your body, that causes some worries and fear. Or maybe it's that you have symptoms that have... It could also be that you have these symptoms that have changed your life, that have stopped you from attending school or attending work or being able to do the things you love, and it might make you a little bit sad or depressed. I think having these emotions is pretty reasonable. It's also a possibility that you could have both. I think it's okay to have anxiety and depression before symptoms ever occur, and that not be so much related to your symptoms. I think that's a possibility too. It could be some separation there. Something we have to consider. And we do know this has a big impact on life, and that does affect emotion, kind of like was said. And along with the depression, there's often these times of loss. Loss can be a loss of friends. With the patients I work with, sometimes they say, the people in my life, I had friends, but, I'm just a lot to deal with. And they don't, they invited me at first, but I have to take breaks. I'm not able to do the stuff they want to do. They want to be active. I live in Florida. They want to be out in the sun. And it's just not something possible for me. So the invites come less and less and less. And unfortunately, it happens from family members too. I often hear, while some people are supportive, there can be family members who just don't get it, who don't believe that it's a real thing, who don't understand why the symptoms can be so severe or having such an impact on the life, and they feel like they lose those family members. And the loss can be just the loss that happens in life. We can grieve the things we lost. I lost my sport. I lost my job. I lost this opportunity. And these parts of life that were part of me one time and no longer feel like they are. And along with that, there can be difficulty adjusting. Again, if we have symptoms that come up, they change a lot of things in our life. That can be troubling. That can be hard. And just coping with this new lifestyle or a new way of doing things and modifying your daily life is difficult. Now, all of these things, all these emotions do affect the autonomic nervous system. So it's almost impossible, I would say it's impossible to separate emotion and symptoms. I'm not going to say it's the cause of them, even if we all together said, oh, this person is very, very anxious and it's a driver in their symptoms, it would be oversimplified and incorrect to say anxiety is the reason. This is way too complex. There's way too many things that add in to give us the symptoms and the presentation we have to just blame it on one thing. But we can acknowledge that all of this does impact the sympathetic nervous system. It does cause some disbalance in the autonomic nervous system, and therefore can relate to symptoms. So it's why mental wellness is part of our treatment, but by no means are your symptoms because you have anxiety. That's not how this works. All right, quality of life. Now, this is a construct I really like talking about. And quality of life, we can typically think of, it's self-explanatory, but how well things are going in the domains of life that matter to you. Now, up here, I have some of the big ones, but this isn't an exhaustive list either. We can think of literally any domain that's important as a domain of quality of life. Now, in the kids I work with, school is often a big one. And how does dysautonomia get in my way of attending or learning or completing my homework? And similar concerns come with work. When we're talking physical, we're thinking more of, am I able to go out and do things? Am I able to be active? How long can I go without taking a break? Are there physical things that I used to do that I can't now? Social is going to be more of, do I have support, not just for my condition, but really, do I have friends? Do I have people I can talk to when I'm feeling down? Things like that. Mood, self-explanatory. That's all of how this affects emotions. But we could go on. We could talk about safety. We could talk about access to care as different areas of quality of life. We could talk about independent living, your ability to ambulate around the home, to get ready, to take a shower, to stand and brush your hair, things that are often taken for granted, but with dysautonomia can be things that can be quite challenging at times. And again, can keep the list going to anything that matters in your life. Now, this is something, I have a few citations on here, but quality of life is an area, there might be a dozen studies, but really not a lot of information. What we do know is that generally overall quality of life is negatively impacted by having an autonomic dysfunction. And this makes a whole lot of sense. We're not surprised by this at all. if you have symptoms and they get in the way, it's going to affect you. But the big ones, the ones that repeatedly are found to be impacted, the physical and the social. The physical impairments being the strongest one, it's also the one that's been examined the most. The thing we find with it, and it makes sense, I'm sure, when you read it, the worse symptoms somebody has, the worse their quality of life is. So if you're having really mild symptoms, it's probably not impairing too much. You're probably still doing okay, although there's some things that can come up. However, when symptoms are really hitting you, when things feel unmanaged and uncontrolled, that's when we get this quality of life that really starts tanking. Now, there's some areas we're uncertain about. For instance, the emotional, the psychological mood area of quality of life, very few studies on it. The ones that are there, some of them show that, yes, this is impacted. There's a couple studies that show that quality of life is the psychological, the mood is impacted, but that is because of how much of a change has happened in the physical. And I'll talk about that in a second. And lastly, the level of independence. This is an area I think is huge because of how many people I know, at least, that talk about it being impaired, yet really hasn't been looked at objectively in the research. So we know it's an area that's being impacted. It's just not one that we talk about a lot. And I mention the research so much because that's where your providers look. That's where they're learning stuff from. And so rather than them having to learn only anecdotally through their patients, if we have more research and we know more about these, then they're already aware of some of the problems that you might be facing. All right. There we go. Oh, wrong way. Let's go this way. All right. So the physiological change is the big driver of quality of life. And that's the physical impairment piece. So when we're not able to get out of bed like we want to do, when we're not able to go to the store and walk around and do the things that we once could, when we're not able to go out places and enjoy them, even just some of the basic outings, that's what really impacts the body. That's what's impacting the quality of life. Like I said a second ago, more so than the mental health aspect. I really reiterate this because a lot of times providers will inaccurately think the opposite. They'll think this is a psych problem and therefore you're having these symptoms and having these impairments. That's not how it works. That's not what the research right now shows us either. But because it's so important, the physical piece, that's where a lot of the priorities are. So when you have providers thinking about, well, what is the best intervention to use? We're always thinking about how do we improve functioning or how do we improve things in the physical range? Because if we can get you doing more, even just a little, if we can get you more active, get you out more, typically quality of life starts to increase. So that's our goal. Now, I said this is an area I like, and I actually wrote a paper on this. This was with teens. It's a qualitative study. And a qualitative study is where you get typically a small group of people that you're looking at. You interview them with questions to find out more about a topic. Mine was the experience of living with, mine was POTS specifically. But I like to think that these results would, again, apply to any type of dysautonomia. Granted, these are with kids, but the results, when I heard them, they're, again, very, they're broad. They're things that can relate to a lot of different people. And with qualitative research, what we'll do is we do these interviews until we reach saturation, which this is a fancy way to say no new topics come up. We take all this information. For my study, I want to say is 120 pages of single-spaced dialogue, which is a lot to sift through. And these are the themes that we came up with. Now, none of these should be surprising. I doubt they are to any of you. You've probably experienced some of this, and I can't see you all right now. I bet there's some people nodding. First theme was just the negative impact this has on quality of life. I mentioned it a second ago, obviously, but this is something that was seen throughout everyone, that physically, emotionally, socially, in school, it's impacting me in a negative way. The second one, and the one that, I love the study, I hate the results, the invalidation. It was just a common trend. It's a common trend when I talk to people. It's unfortunate. from doctors, from family members, from people at school, from teachers. One girl was talking about her experience with a principal where kids are just not believed about their symptoms. And through this, the concept of living with an invisible illness. I don't have a big cast on. I don't have a big cut. There's not something that's visible to everybody, but I am struggling and they don't understand what I'm going through. Along those lines, the need for trust and advocacy came up. So trust was more of a thing with parents and kids. For kids to trust your body, that would work for adults too, the adults on here, to be able to trust your body. Obviously, your body's doing things that you don't like, things you can't always control, but to know that what you're experiencing is a real experience and having trust in that. And for parents, it's, you know, your child, you know, your kid's not faking. You need to be there for your child and advocate too, and help them advocate, because that can be such a problem when there's so many people that don't understand or even, of course, don't believe the condition. And along with that, POTS is a novel condition. Every form of under the dysautonomia umbrella is technically a novel condition. These are things that are still somewhat new, things that most medical providers did not learn about in med school. And even the ones coming out now, we're talking hours, not days or weeks that they spent learning about this. And so because of that, we need more information, we need more resources, and we really just need a broader level of understanding amongst the medical community, amongst our friends and our circles. Now, again, these are things that shouldn't surprise you, but I'd also say this isn't an exhaustive list again. There's many more ways that life is impacted by any type of dysautonomia. But of course, these are just the big ones that we found. Now, along with this, I want to share a couple quotes that came from the study, just because they always hit me pretty strong, this situation especially. And while for a teen, I imagine there's parallels that you may have experienced in your life. So one, this is a mother talking about her daughter, says, the GI specialist said, think healthy thoughts and you'll be healthy. What does that say to a type A kid who is successful at everything they do? You're not thinking healthy thoughts. That's why you're sick. And so this is all in your head, basically. And another one, would get in the car after one of those doctor's appointments at the specialist, and she'd just break down just in hysterics and just be crying and sobbing and saying, what's wrong with me? Why do they keep telling me there's nothing wrong with me? I don't like these. I don't like them because they show how much this can affect somebody. That somebody goes to their provider, you have real symptoms, you have real problems, there's things you want help with, and they basically tell you, yeah, just have helpful thoughts, be more calm and you'll be fine. And it's more complicated than that. And as a psychologist, I want to help people with the coping and the mental part. And I do want people to have healthy thoughts, but that is such an oversimplified and inaccurate way to discuss the treatment of such a complex condition. And of course, this invalidation is not just specific to the patients that I had in my study. This is something that, unfortunately, the vast majority of people with dysautonomia experience. And something needs to change with that. But let's think about this invalidation for a second, because I do think it's so important. When we're thinking about invalidation, there's a lot of questions that then come up as a result from that. Because if you're a patient, you go to a provider and the provider has all these letters behind their name and they've studied and they're smart, and I need to believe them because that's kind of what you've been told your whole life is I go to the doctor helps me. And now they're saying that this isn't real or this is fake or that you're crazy or something terrible of that nature. So then you go home and you say, is this anxiety? And the rest of the questions. Well, as a psychologist, I can actually comment on some of this. Is this anxiety? And the answer is no. Can anxiety play a role in your symptoms and worsen stuff? Absolutely. But again, that is not why you have an autonomic dysfunction. And people ask, is nothing wrong with me? Because they're basically saying this is all in my head and my body's fine. And that's not accurate either. Obviously, something's happening. All your symptoms are valid, real symptoms that are occurring. And people ask, am I crazy? Because they do keep on mentioning this mental health piece. You're not crazy. And now these symptoms could drive you crazy in a very colloquial way, that they bug you, they irritate you, they're annoying. And when you have providers that aren't listening, when you have providers that don't believe you, or that aren't treating you in a way that is holistic, it's hard to not have that thought, but no, you're not crazy. These are real symptoms. The last two, though, who's going to help and who's going to believe you? I like to think that there are good providers out there. Actually, I know a few of them. There are people that believe, there's people that understand. And sometimes that can be hard to find. I mean, depending on where you're at, depending on the services nearby or who you have. So it can be difficult to find them. But hopefully there's other people you can find in your life that can help out with giving you that support. That's where the next part comes in. And we're going to shift over towards the more practical implications of this. What can be done? What can you do? I like to break it down into 3 areas. I'm sure there's more ways that we can help you. I'm sure there's more ways that you can help yourself. But these 3, I think, really get us started. So building your network, advocating, and education. And I like to think that all these can happen simultaneously. It's not like you have to do one first and the other. In fact, if you're doing all 3 at one time, I think that's actually pretty beneficial. Because if we're getting education, we can educate our providers in a kind way. And if we're learning stuff, we can share resources with other people, and we can advocate for ourselves or to our family. And if we're building our network, we have more people that can support us and help us with that. It all just goes together. Let's go through these slowly, though, because I do want to make sure I drive this home, because I think they're so important. First, with advocacy. Who are you going to advocate with or for? What do you say, and do you have the confidence to say it? We need all 3 of these answered. First, with who, we have to decide who needs to know about this. Is it your friend? Is it your family member? Is it that person in a social group? Is it your provider? Who is the person that you need to advocate for? And in advocacy, we're thinking about allowing somebody to really understand what you're experiencing, to get the care you need, to get the support you need, or to rebuild bridges that have been damaged. The next is, what do you say? And whenever we're more well-informed, we do better. We're going to learn, well, that'll bleed into the education piece. But if we know the facts, we know the recommendations, I think that's where we start with the information. That here is what I've been told, or here's what I found out. And then to ask your provider about it, to say, hey, what do you think about this thing that I've learned? I think it's also nice, if we're to do advocacy, is to be around other people that can help us advocate. You're all part of a group. That's a great place to start. And lastly, is having that confidence to say it. This can be tough, because I don't want to upset my provider. I mean, it's my provider. I don't have another one. I need the medication, or I need to see them for other things too. And it's not worth the battle. And yeah, my family member is really annoying about it and validates me, but they're family, and I don't want to start a problem. I only see them over at Thanksgiving, and I don't want to be the person starting a fight at Thanksgiving, or something of that nature. But it may be there's a way that we can say this that does allow us to get that help we need. And it's something that I would encourage you, practice it. Practice in the mirror, practice it with a friend, practice it with somebody in the group. Practice the thing you need to say to the person you need to say it to, in order to get yourself that service, or get yourself that support you need. As said, education helps with this. I have an exclamation point with these: learn, talk, ask. These are all good things. Now, there's many sites out there. If you just Google search anything about treatment for whatever condition or symptoms you may be seeing, dozens and dozens and dozens of sites will pop up. Now, I've done work with Dysautonomia Project and Dysautonomia International this year, so I can say both of their websites have an incredible amount of information. There's surely another dozen great organizations, and I'm sorry I haven't worked with all of them, and I can't name everybody off at one time, but should be information that can be accessed either through your group or who you have. But I think this is important. The more we can learn, the more we understand it, the more we can talk in an educated manner to our providers about what's happening. It's helpful. I've heard some people, in a very kind way, providing articles or information to their provider. And I think that's okay if your provider doesn't understand, to give them information that is. And I'd also say talking to other people with dysautonomia, talking amongst support groups and things, talking to providers just to have the dialogue running. Again, we know that this isn't a common condition. Well, actually, that is very incorrect. It is a common condition. It's a common condition that's not commonly talked about, that's not commonly known by the medical profession or just the public. So the more you talk about it, the more the conversation comes up, the more people learn. Now, the ask piece. Ask questions to your friends, ask questions to the people you have in your support group. But I'd say ask questions to your providers too. If your provider is recommending or not recommending an intervention, ask them why. Get a better understanding and feel for what their conceptualization is, for what their treatment approach is, because hopefully they have a good reason for whatever they're doing. And if you have genuine concerns, you should be able to ask, which is going to help you understand your care more and hopefully help you be more collaborative with your provider. And again, always ask in a respectful, collaborative way, because I don't want you to burn a bridge. I want this to be something where you feel like even though my provider doesn't know all they need to yet, I can get them to that point. And this is tough. It often takes advocacy. It takes a lot of work, and especially just the confidence to do it when you've been invalidated can be incredibly difficult. But like I said, the more you know about the condition, typically the better we feel about talking about it. And then this last part of that circle, which is building your network. You already knocked out the first one, so good job. You have the support groups going. But we really need to find who supports you in your life. Again, it's much easier to advocate. It's much easier to feel confident about what you're doing when you have somebody that supports you. Now, friends and family, like we said a second ago, you may have lost some of these people. They're people that were in your life that said this is too much, or people that said, I don't believe you, or why are you acting like this? And they stopped seeing you. They stopped talking to you or working with you. I like to think that if we're able to educate and help even them understand, we can start rebuilding some of those bridges. Maybe not all, but it may lead to having more support. And then also thinking about community. And this can be looked at in a lot of different ways. Your neighborhood, it can be if you work or part of a club or a civic or a religious organization. Any of those are starting places. And of course, depending on what you're doing, what you like, and what you're able to do. But the consideration is, how do I put myself in places where I can build up this group, and hopefully that can help. So you advocate, you learn, you build your network. What's next? Functioning. When I talk to kids, this is probably the most important thing that I think of. It's living life. Like, if you got your symptoms and they're not really going anywhere, how do we still live a life that's meaningful? And that's where the first question comes up. What's most important to you? What is the thing you want to move closer to? What is the thing you want to be doing? If I'm having to deal with all these symptoms, what's something I still care about and can continue having in my life? Now, for a lot of people, this could be just doing a little bit more of the activity you like, a little bit more of school or work or friends or a hobby. And it's going to depend. There's some things that are going to be limited, and that's just how they are right now. But there might be other areas where you can slowly start creeping back, and maybe not do everything like you used to, a different person with different things going on, basically, but can still try to incorporate things that you love, things that bring you joy, things that provide fulfillment in your life. Now, to do this, it's often helpful to have accountability. That's where that support comes in. And this can be a parent, a relative, a spouse, or a partner, a friend, your provider, whoever. But having somebody that you can say, hey, here's my goal for this year. Here's something I'm going to slowly start working for. I'm going to try to do this every other day this week. And just having somebody that supports you and helps push you to this life you want to live. And often this takes structure and routine. Structure, just because structure can help us kind of see where we are and where we're trying to get, whether that be a daily or a monthly or however you want to look at structure and tracking, but really forming some type of routine. say we're talking about physical activity. Again, not the only thing, it's just one of the ones that's easy to talk about. If somebody's wanting to become more physically active, it isn't that you have to go, walk a mile every day. I mean, that might not be in the cards right now, and that's perfectly fine. But maybe it's, I try every day to do this one thing at this time. And some days you're successful, some days you're not, but you at least get in the routine of, I'm going to try, I'm going to try. And if that thing we're trying is something that's important to you, something that allows you to feel like you're living life, well, then that's awesome. And that's what we go for. Again, this is tough. We need people to motivate us, especially on the difficult days. And we're not always going to have success, and that's all right. It's not about doing everything perfect every time. It's all about moving just a little bit closer. So, psychology. I'm a psychologist. I get to talk about this. How does psychology help? Now, psychology is not just, again, probably been referred a lot of ways that aren't accurate to you, but there are ways that this can be incorporated in care. Start first with adjustment. A lot of people, when you're dealing with a medical condition, you don't always know what symptoms you're going to have, when they're going to happen, how intense it may be. And so it can be tough to cope with the unpredictability of this, and even the unpredictability of how life is going to change, the fear of the symptoms as they come, the grieving we mentioned earlier, the loss that happens, but even just this life. I'm now, I'm not that person I was. I'm not doing the same thing I was doing, which can be difficult. It can be challenging for people. Psychology can also help with building self-esteem in this person you are. And like was mentioned on the last slide, finding ways to live a life that's meaningful and fulfilling. With any type of chronic illness, and I have to reiterate this point, things change. And a lot of times, at least in the teens I work with, and I could imagine some of you in your lives, we look back and say, I was this person and I want to be there again. I want to do that again. I want to be that person, that version of me again. But in a way, that's impossible, because what we've experienced, what changes, the fact that there is a change creates something different. And as a person, it's not that we need to get back to who we were. It's how do we evolve with this change to be a person we still want to be, which I think is something we all have the potential for. And of course, it's one of the things that I believe psychology can often help with. Now, we also do the things that you typically think of with psychology. That's cognitive behavioral therapy, acceptance and commitment-based therapy. Both of these have a little bit of research behind them for work with POTS specifically, but chronic illnesses in general, these are usually the main two we use. And some of the things on here, this sounds like you'd expect with psychology, helping out with emotions, like what do I do with them, acknowledging when they're there, all the stress in life, how do we cope with it? How do we respond to it in a way that's still helpful or gets us to where we want to be? And that stress can come from a lot of places. And then managing things, anxiety, depression, trauma, psychologists do that. All right, there we go. Also, the functioning piece. A lot of times, if the goal is I want to become more functional, it comes with a host of challenges. It's not like you just do mind over matter and just push it full throttle and then you're better. If it was, probably all of you would be better by now. You want it, but it just doesn't work that simply. Instead, what we're doing is this slow, arduous, oh, my lights went out. There we go. This slow, arduous move towards functioning. And that comes with pacing and gradually increasing. It comes with structure. It comes with what do we want to get back to? And even the fear of getting back to things. I mean, I think about the kids I work with, and if they haven't been in school for a long time and then going back to school, well, people are going to ask questions. People are going to judge me. What if I'm using a wheelchair? What if I'm using some other type of assistive device? And so we're overcoming those barriers too that come along with it to try to help people get to where they want to be. And then there's motivation that can come in with it. And we talked about having somebody that's a support or that can help push us some. The meds, the exercise or physical therapy, just doing everything with salt and hydration. Sometimes people just need a little bit of oomph with those things. Again, that's not the entirety of a treatment program, but it's something else that psychology can assist with. Oh, wrong way again. And then the other thing that psychology helps with, the last thing I'm going to mention for psychology, is self-regulation. You can think of this as relaxation skills. Some people refer to it as mind-body skills. I think of self-regulation because what I want is for these skills to help regulate the autonomic nervous system, very literally focused on what's happening inside your body. If you're not familiar with these, I'll briefly introduce them. All of these you can find online. You can YouTube them and have somebody walk you through them. You can find scripts where it's written out for you online. There's tons of resources out there. Mindfulness is more of this focus on the moment, on what's happening in a non-judgmental way. So this form of acceptance, whether we're talking about our emotion we're experiencing, what's happening in front of us in life, or what's happening inside of us sensory and what we're feeling and experiencing. There's diaphragmatic breathing, which is belly breathing. You've probably heard of this, and I'm sure all of you have been doing breathing well enough for however old you are, but really focused on pace. So if you're breathing in 4, out 4, breathing in 5 and holding 1, and breathing out 5 and holding 1, it just needs to be a mirror. And that just helps with how oxygen and carbon dioxide are balanced in your body, which helps the autonomic nervous system. So for any type of dysautonomia, I always say pace the breathing if you're trying to do more of a self-regulation technique with it. Progressive muscle relaxation, which is tensing and relaxing your muscles. Think stress ball, like the tight and relax, focusing on the relaxed part. Obviously, we're trying to cool the body. Also, that helps with pumping blood through the body. So a lot of people before they stand will squeeze and relax their arm, or not their arms, their legs, their feet, their thighs, to try to get that blood moving before they have to stand. And then biofeedback, which is basically a tool that we use to practice those. It's typically there's a screen attached to us, some sensors that attach to you, which look at your heart rate, blood pressure, respiration, temperature, muscle tension, all those things that are controlled by the autonomic nervous system, shows you on a screen so that then you can watch it, understand it, and change it more in real time in your body. So it makes the skills a little bit easier to learn. Not everybody's going to have access to that, but it is another thing that can be helpful. And there's some research behind all of these for why they should help out with any type of dysautonomia. So there is hope. And I say this knowing that there's probably a wide range of people on this video. There's people that are more new to dysautonomia and what's happening in their body. There's people that are doing better, that have had some steps in the right direction. There's people that are feeling like every day is a little bit worse. And there's some of you that have probably been struggling for months or years or longer with this condition. But regardless, I think there's hope. First, everyone's unique. So it isn't that, okay, I tried this and it didn't work and therefore I'm done because this is the treatment. Rather, what we have is an opportunity for trying different things. And that's the one, I guess it's a benefit of this being a novel syndrome. The science is so new on it. So we don't know everything about it yet, which is frightening and at times can be troublesome, especially if your provider doesn't know about it. But it does mean that we will learn more and more will come up. And the strategies, yeah, we have a good handful of them, and there's things that we recommend that we believe help, but over time they will get more refined. There will be better ones. And same thing with the medication. In the last 3 years, in the last 5 years, in the last 10 years, in each of those time periods, more and more has been known, and medications have become more and more focused on the symptoms that are experienced with dysautonomic function. And so these are all things to realize that can change, that can get better. And part of it is just, how do I keep on getting through right now? Knowing that there are new strategies and new science coming, and they're coming out rapidly. How do I keep on allowing myself to be in a place where I can get them later? And also to think about your body. There's hope in that your body, your nervous system, your brain, it's ever changing in a way. And what you're experiencing now what you're trying now to help your body may not be effective now, but later in a different context with knowing different things in your body changing too, the same treatment may show you much more improvement in the future. Again, lots of things can change, and a lot of things can change for the better. Now, the goal is not perfection in any of this. You don't have to be perfect with your medications. I mean, try to take them as recommended, but you don't have to be perfect. You don't have to be perfect with non-pharmacological interventions and drinking exactly the 120 ounces of water and 4 grams of salt and all of this. Those are just numbers. But your goal isn't to make leaps and bounds and to feel like you're getting better every day or every week. That's not the point of this. The goal is, how do you slowly work to be a little bit better in the terms of who you are and who you want to be? That when the year ends, maybe your symptoms haven't changed too much, but who you are, what you're doing in life, and what's important to you, you feel like you're closer to that. So, to put this together and wrap this up, dysautonomia, or any of those conditions that fall under that umbrella, they are not mental health conditions. I'm a psychologist. This is the area I study and care about. It is not a mental health condition. We have a book, big old book called the DSM with all our mental health conditions. It's not in there. So if told by a provider that this is mental health, it is not. Mental health, of course, it plays a role in the body. You can't separate the emotion and the physical, but it is not the reason you have your symptoms. Okay. With that said, what you're experiencing is difficult, incredibly difficult. And some of you have really been intimate with that difficulty in the ways that it's impacted your life. And it's okay to get help. It's okay to get help from psychologists. Obviously, that's why I'm giving part of this talk. It's okay to get help from providers. It's okay to get help from friends. I know a lot of people who will say, well, this is a burden I have to bear. I don't want to be a burden on somebody else or bother them. Please do. That's why we want you to have a support system. That's why that's so important, is because this can be such a challenge. And so the last part of that is just to find the resources that help you function. Finding the right intervention, finding the right provider, finding the education, finding the support system that allows you to move forward. And with this, it's a tough condition. It's something that is very complex in both how it comes about and how it's treated. And if we can take some of this, hopefully what it can do is get you to a place where you feel like the functioning improves a little, or at least, again, we're living a life that's close to what we want to live. So I thank you for your attention and your time. I thank you all for being here. And I think Morgan's going to help me out with opening up for questions if you have any that have been there. And I'm going to stop my share so I can hopefully see some of you. All right. Thank you.
Thank you. Thank you, Dr. Frye. That was a wonderful presentation. You hit a lot of topics that are so important to all of us. And so thank you. And I'll let you go ahead and answer some questions.
Sure.
Thank you. Okay, so like he said, if you guys have any questions, feel free to put them in the chat box and we will go from there. It does look like we have one question so far, and I'm not sure if this is more directed at Dr. Frye or Dr. Trevino. But Chris is asking, how do we stop like the high consumption of salt from harming us?
That's a good question that my lack of a medical degree is going to probably not let me be able to answer in an adequate fashion. So Dr. Trevino, if you got this one, I am all for it.
We have to unmute everybody. Okay, Dr. T?
It looks like his mic isn't working.
Oh, no.
Let's see.
Well, and Chris, actually, if you'd like to elaborate while we're figuring out Mike's stuff, could potentially be helpful.
Yeah, it's just that I have POTS and my 10-year-old daughter most likely has it as well. But we also follow a whole food plant-based diet, and we're told salt is the #1 killer in the US. And we're not in the US, we're in the UK. But We follow a doctor called Dr. Greger, who says we shouldn't even eat fermented food that's fermented in salt because it's been linked to stomach cancers. So I'm a bit nervous about my 10-year-old consuming too much salt.
Sure.
I mean, I think I can maybe add a little bit. Obviously, I'm not a physician, I'm in PA school. But from what I know, the damage caused from salt is usually hypertension. Long-term, like high blood pressure is what initially leads to like strokes or like the concerns that we do have. And with POTS, normally your blood pressure is on the lower side. And so the point of the sodium is to try to increase that blood volume and increase your blood pressure. And so I don't think it harms us in the same way.
Right, okay.
Dr. T, maybe a yes or no, if that's a little accurate.
You're muted, Dr. T.
Oh no.
I sent you a request to unmute yourself.
We had him going earlier.
Well, I think that was a good answer, Morgan. Thank you.
Thanks. We'll see if it's right.
Yeah, and I would also encourage keep talking to your provider because they might have alternatives that they want you to consider. And again, it's your provider, so they probably have a plan behind it. So definitely consult with them more about what other options you can have.
Thank you.
Okay. And then when trying to find a psychologist, what should be the right questions to ask to know if this particular provider is able to help with a patient with POTS or maybe other chronic conditions?
Oh, great question. This is, I think, one of the big ones that a lot of people struggle with. First off, let's just say that if we think about psychology training, for instance, it's not all the same. And a lot of times people do not have experience with chronic conditions. So most people, they're trained in certain areas. So my training in grad school was primarily clinical child psychology. So, you learn about the basics, anxiety, depression, ADHD, all the fun stuff you see in kids. And through that, I also had experiences where I got to work in hospitals and things like that. Now, I specialized in chronic illness, so therefore I was able to say, oh yeah, I know this. And a lot of it then became part of my practice, which really grew my understanding in things like POTS or mast cell or EDS and all that. The reason I mention that is because it's hard to tell. You can sometimes look at somebody's training. Sometimes they'll have it on the website and it'll say that I specialize in this, and this, and they may mention something that's similar. Sometimes you might just have to ask around the people in your community, hey, or if you know people in your community who have chronic illness, to say, hey, who do you see? And then also, I think it's okay to interview if you're looking for a psychologist to ask them questions. A lot of the people I know, even the psychologists I know that see a psychologist, they will talk to them beforehand to see, hey, here's what I'm working with. Have you worked with it before? I think that's a big question to ask. Have you worked with chronic illness before? What's your approach to this? I think questions that make you feel comfortable. And that's the biggest thing, whether they have a ton of experience or not much, you got to feel comfortable with who you're working with psychology, or it's never going to really work. It's icing on the cake if we can find somebody who has a lot of experience. But yeah, the big thing is just making sure you're comfortable and maybe they have some knowledge. And if you can find somebody that through your community that knows who works with the population, even better. Oh.
Well, I think I heard Dr. T.
Yeah. And I think there's more to the question.
Sorry. I was trying to get my mic to work. Can you hear me now?
Yes.
You want to elaborate on the question about the salt?
Yeah, so I get this question a lot that this is way too much salt for me. I have high blood pressure because a lot of people they either do have high blood pressure or they have too much adrenaline at different times in their body, so their blood pressure actually goes up, and so they're afraid to take that much salt. But what we're trying to do, so especially when you have pods, what happens is when you sit up or stand up, initially your blood pressure drops, and that's what triggers a signal to your adrenals to start producing a lot of adrenaline, which then raises your blood pressure. And so what we're trying to do with the extra water and salt is to initially help with that drop in blood pressure. And so that's why the Florinef helps, medications that make you retain salt in water help. So actually what happens is it seems like counterintuitive, because what happens is the extra if you have high blood pressure because of too much adrenaline, the extra salt will actually help you lower your blood pressure because it helps decrease the amount of adrenaline you're producing, which is causing all the blood pressure.
Right. Thank you.
Sure.
And then Dr. Frye, you said there was another part to the question that you wanted
Oh
to...
no, I think I saw the chat and it was a new person.
Gotcha. Okay.
LLC.
Let's see here. So for LLC, it looks like... Okay, so her heart rate went from 70 to 150 standing. Should she have more tests to confirm, even though her doctor said that's enough to diagnose POTS?
Yeah. Dr. Trevino, you're gonna have to back me up on this one. But typically POTS is a diagnosis based off that criteria. And I think it's really just the change that happens. Some people say you got to do a tilt table test, but that's not part of the actual diagnosis to have a tilt table. It's usually based off symptoms, and especially the symptoms of what happens when you go from laying to standing. Dr. Trevino, please add to that though, because you do more of the diagnosis than I do.
So yeah, so the criteria is that if your pulse goes up 30 beats per minute, if you're over 12 or 13, but if you're younger than that, then maybe 40 beats per minute from a lying down to a standing position. You have symptoms while standing, and then when you lay back down, everything goes back to normal and your symptoms go away. That's what we're basically looking for. And that's all you need to make a diagnosis. So if your pulse is going from 70 to 150, you're having symptoms and then they go away and you lay back down, you probably have POTS.
Yeah.
Now, some people don't go all the way up to, they don't have the 30 beats per minute. Some will have 25, some will have 20, but they still have all the other stuff going on. So in that case, I would say, yes, they still have POTS. It's just that they don't meet the pulse criteria at that moment or that day. And some people have good days where they don't meet criteria, but then they have a lot of bad days where they do meet criteria. And so if you catch them on a good day, you may not be able to get the evidence that you need to make the diagnosis. But if you catch them on a bad day, and people will tell you this is a good day, this is a bad day. And if they're having a good day, they'll tell you. And if they're having a bad day, they'll tell you. And if you want to make a diagnosis, it's better if you test them when you're having a bad day.
Yeah.
Sometimes.
Makes sense.
All right, thank you. And then part two of that question, if I'm understanding it correctly, I think they're trying to ask if, like, knowing they're about to participate in a specific activity that normally triggers their POTS, do you think just knowing it's about to happen can trigger it in general, like before the activity even occurs?
Potentially, this one's tough. So doing some of those things, like think about a field day. I mean, you're running, some people just being outside or in the heat, all those things are potential triggers. And most likely, you know your triggers pretty well. I mean, most people on here, if you've dealt with it for a while, you kind of know, okay, this causes more symptoms. We could potentially say that fear of it does increase it, because if we're just thinking of what does fear and anxiety do, is it raises the heart rate, it throws off our breathing, it creates more tension. There can be stuff that can add to it. I think it's probably very specific to your case. So without knowing everything, I don't know if I could say, and this is the reason why, and yes, it's fear. I think that would be a little bit of an overstatement. It is probably a little bit more complex than that, but it can play a role. Let's go with that. So yes, anticipation can absolutely play a role with any type of symptom, whether we're talking dysautonomia or other things too.
Makes sense. Thank you. And then Cindy, I believe you sent the question in about the common medications used for autonomic dysfunction.
Yeah, from a psychology standpoint, are there any particular meds that you are seeing that help us? Like, do we take the ADHD, the Vyvanse, or do we take the other meds? And are there any antidepressants that you have seen that are more effective with autonomic dysfunction patients or not?
As a psychologist who has no medical prescriptive privileges, I cannot answer that in terms of like, here's what it works. And I think that the use of any medication, any type of mental health medication or medications that's traditionally for mental health, use for dysautonomia is off-label. Yes. With that said, I've seen things happening, although I don't think there's any evidence to say that this medication is what you should do for it. And you've probably heard of some of it. Some people look at SNRIs. Some people look at stimulants for more like a brain fog type thing. But that's something you definitely want to talk to your provider about and not take my advice on, because I am not able to prescribe or recommend medications. So do talk to your provider if you're interested in that. I think that's a very good question to ask them. And there are some out there that people use.
Do you have any thoughts on that? Are you seeing any, I don't want to say a trend because we're all so different, but are you seeing any?
So what I kind of see all the time is people who get, who have too much adrenaline causing their symptoms. They feel shaky and jittery, and they get misdiagnosed with anxiety, and they get prescribed anxiety medications, and they don't have anxiety, and don't even tell you, I'm not anxious, I just feel shaky and jittery. But my primary, or whoever I went to, says and that I'm anxious, and so he gave me these benzos or gave me SSRIs or something, and usually what I'll do is I'll try to kind of wean them off if I can, give them a medication that would help them more with the symptoms of having too much of it.
Okay, thank you. And then let's see here. And then what about dysautonomia causing GI issues? Is there a correlation?
Absolutely. If we think about the autonomic nervous system, so autonomic nervous system, it's got your sympathetic, your fight or flight system, your parasympathetic, that's your rest and digest system. And so all that's controlled by there. So think about a body, or excuse me, think about a fight or flight situation. You're running from an animal, or an animal running from an animal. Like a zebra running from a tiger is my favorite one. All kinds of things happen with the heart rate, with the lungs and respiration. But also what the body does is to prepare for fight or flight, it has to stop digesting food. And usually for an animal, it evacuates everything that's in the stomach. And for humans, we don't run around with a stress response that's making us throw up and defecate on ourselves all the time. Rather, if we have a disruption with the autonomic nervous system, it's going to cause smaller problems in the GI system. And so, yes, that's part of where you get the GI issues from. So super common. I think most of the kids I work with, there's some type of GI issue there too.
Okay, thank you. And do you have experience treating patients using any forms of CBD and how it can affect their outlook positively and help them relax the anxiety symptoms?
I have a son in my throat, so I might cough again. Excuse me.
You're good.
This is the most controversial question that always gets asked psychology. And such a good question because there's so many people that think very strongly on either side of the fence. So especially with kids, I'm never going to recommend CBD or marijuana. It's just not going to happen. Developing brain, there's too much that's not known about it, or there are potential problems that can come with it. So I think the risks outweigh the rewards. CBD's also changed a lot in the past few years in how it's manufactured, different ways you can take it, and the response you can get from it varies very drastically between people. With that said, some people love CBD. They say that, yeah, the oil or however I use it works for me. It calms me down, which is nice, and we could say would be helpful. Other people say I tried it. It didn't really do much for me. If we look at the literature, there's really not much there that would say this is an effective way to deal with anxiety nor dysautonomias. It doesn't really come up as something that has any evidence behind it. With that said, again, some people really do get a response from it or feel like it's something that's helpful. This is something else I would say talk to your provider about. Different providers are going to have different perspectives. CBD, especially without THC, is a little bit more legal in most places. So depending where you are, there shouldn't be problems if you want to try that. And I'll give you my personal opinion on this type of thing. With anxiety, part of the treatment typically is to expose yourself to these emotions and sensations that don't feel good. And that's a lot of what the treatment is. If somebody's scared of dogs, we slowly introduce them to dogs, starting real small, get to bigger, more aggressive dogs. And that way they learn that this is safe, this is okay, or here's how I respond in an ambiguous situation. If every time we're worried, we take CBD or THC or whatever we want to use, it helps us avoid the situation, which really just causes the anxiety to grow until we start having to have it. It's necessary that I have CBD so I can face this fear. And I have personal friends that they do it with marijuana, where they have got to a point where if they're not smoking on a regular basis, they're very, very anxious, and it can be quite distressing. So, if it's part of what helps, awesome, but I don't think it's a long-term solution. And sorry if anybody on here like CBD sales is your main area, because it probably has its helpful parts too. But for my personal recommendations, it's not part of what I'd have in the treatment.
Thank you. And next question is, any suggestions to help with coat hanger pain? I noticed it helps significantly when I go in a lake or a pool and tread water. Are there any other methods that could potentially help, because I don't have access to a lake or a pool all the time?
Ooh. Dr. Trevino? Because I'm thinking of things that, relaxation type things, but you might have other ideas too.
So usually coat hanger pain is pain that is associated with being upright in patients who have thoughts. And usually I view it as something that is related to when you sit up or stand up, there's decreased amount of blood flowing up into your head area. So anything that, so when you get in the water, of course, you're more horizontal. You have the pressure from the water, which helps, I guess, get more blood into that area. And so I think that's why maybe the water helps you. I think in general, if you treat the POTS with all the things that we do, compression, water, salt, exercise in the laying down position, etc., then the coat hanger pain seems to also be good.
Okay, thank you. All right, and then I believe that was the last text box question. Does anybody else want to add anything or ask anything else? Okay. I think I have my own question. I know a lot of us started out as like perfectionists, and then you kind of get knocked down, like it's usually like the type A personalities. I know like a lot of people struggle with the guilt of like knowing when to push yourself versus when to like take a rest day. Do you have any advice on how to like alleviate the guilt of like, should I push myself or should I stay home?
Oh, what a big question. It's such trial and error too. I mean, because I think a lot of times, if you want to do something, you push yourself. And I have some patients that are like, yeah, I know I'm going to pay for this for 2 or 3 days, but I don't care. This is important to me. And I'm like, go for it then. I mean, if it's okay to you and it's what makes life all right, and you're all right with being down for a couple of days, I don't mind. I think it's hard to turn off that perfectionist side of the brain, though, that you mentioned, because when you're used to, I work hard, this happens. I work hard, this happens. I get the results because I work hard. it just doesn't apply for this. It's quite the opposite, actually. And so I think at some level, sometimes it takes working with somebody to be a little bit easier on yourself, a lot of grace, a lot of gratitude, and changing the expectations from I have to be perfect to, I like who I am, I'm enough, and I can still do this, this, and this, which is probably good in general if we're talking about just perfectionism or perfectionism plus a dysautonomia. But that's what I'd say, a lot of grace and a lot of just, if we're doing the things we enjoy, the things that are fulfilling, to accept that and not feel like we have to be 100% at all times. It's not feasible, really.
Yeah. Okay, makes sense. Thank you.
That was one of the hardest adjustments for me, Morgan. Being a perfectionist, always being able to do everything and then couldn't do anything anymore. That it probably took me 5 years to finally be able to go, okay, well, that's not done perfectly, but so yeah, I agree. Just definitely give yourself grace, because I had to do a lot of that, and that wasn't comfortable for me either. So I
Yeah.
think one more question come in. Lizzie, you sent it in, or did you already read it?
Yeah.
Yes, we already went over that one.
Okay.
Oh, that last one, Lizzie. So the chat, if everybody can't see it, it's a great little dialogue on, and if I'm seeing it correctly, on being a mother and noticing your child and getting them to the right place, and you being the advocate as a parent for a child, which is absolutely correct. They're talking about hyperadrenergic POTS, and there's some research that's kind of up and coming saying that there's 3 separate types, or at least 3 subtypes. There's still a lot to be done to really piece those apart, and they probably have some overlap, but that's not for right now. But rather, this one's saying, in this case, the sympathetic nervous system is just stuck on overdrive all the time. And so any little tiny things, including triggers, little tiny things, including thoughts, maybe not tiny, can trigger this response, which makes total sense. So again, everybody's very individualized. So if you notice that it's the thoughts that are triggering this bigger response in the body, well, let's work on treating those thoughts. If we notice that it's the actual physical activity, well, then yeah, we got to balance how much we're doing, or we got to pace into it, or consider what all we are doing in the day. But yeah, as parents, props to you. The parents I work with, have gone to 10 doctors and take off time and go to hell and back for their kids. I mean, it's just a really tough position to be in, but also the person that can really drive good care for the patient.
Yeah, we really have a big heart for our caregivers, because there's a lot of feisty mamas out there that aren't going to stop until they find the answers, and kudos to them. So, well, I think that, all the questions. Does anybody else have any questions? Dr. Frye and Dr. Trevino, thank you both for joining us. We really appreciate the fact that you two take your time on a Saturday afternoon, your private time, and provide these talks for us. And we just can't thank you enough. I think Morgan's going to read the disclaimer one more time, and then everybody could go have a good Saturday afternoon.
Yeah. Thanks, everybody.
Thank you, presenting. Thanks.
Alrighty, so by participating or listening to this content, you agree not to use the information presented here as medical advice in treating any medical condition. Form does not constitute a provider-patient or physician-client relationship. Content here is for informational and educational purposes only, and because each person is so unique, please consult your healthcare professional for any medical questions.
Yes.
All right. Thank you.
Alrighty, thank you guys.
Thank y'all.
Bye.
Have a great afternoon, everyone.